Good morning, everyone. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about laparoscopy. So, what we wanted to discuss today: the definition, the application of laparoscopy, patient positioning, equipment, procedure, advance and complication, and lastly, the recommendation by the Canadian Society of Obstetrician and Gynecologists 2020. Okay, so what is the definition of laparoscopy? This is one of the minimally invasive surgery in which operations are performed far from their location through a small incision, usually between 5 to 10 millimeter elsewhere in the body. And it is a surgical procedure in which fiber optic instrument is inserted through the abdominal wall to view the organs, abdominal or pelvic organs, or permit surgery with help of pneumoperitoneum. So we can diagnose many lesions and we can use it also as a therapeutic tool. As you see in this picture, this is a picture of laparoscopy. This is the uterus, and this is the right and the left fallopian tube, right and the left ovaries. And this is the Douglas pouch. Okay, so laparoscopes or telescopes vary in size from 2 to 10 millimeter. And also the viewing angles may be 0 degree, which give panoramic view, which is commonly used in gynecology, or 30 degree, or 45 degree, or 70 degree. As in this picture, you can see the difference in the angle of the lens. This is the telescope, this is the eyepiece, this is the lens, and this is the light source here. The doctors see the inside of the abdomen and the pelvis on the monitor like that. So what is the application of laparoscopy in gynecology? We can use it as a diagnostic tool or as a therapeutic modality. What is the indication for laparoscopy in gynecology? We can assess pelvis for acute and chronic pelvic pain. We can diagnose ectopic pregnancy as in this picture. This is ectopic pregnancy, pupil ectopic. We can diagnose endometriosis, adnexal torsion, or other pelvic pathology. We can do injection of methylene blue through the cervix to see if the fallopian tubes are patent or not. If coming through the fimbrial end, this means patent, as in this picture. This blue color is a methylene blue coming through the fallopian tubes. So if there is obstruction, there is no methylene blue coming from fimbrial end, so we call it negative methylene blue test. If methylene blue come from fimbrial end, we call it positive methylene blue test. Also, we can detect the hydrosalpinx. The hydrosalpinx, the tube will be dilated and bluish in color, and also there is variation in its dilatation and its size. During diagnostic laparoscopy also, I can take biopsy to confirm the diagnosis of endometriosis or from suspicious mass in the ovary or fallopian tube for histopathological evaluation to exclude malignancy. Also, laparoscopy can be used as an operative or management for many cases like lysis of adhesions, as in this case, there is adhesion between the fallopian tubes and the ovaries, and also between the ovaries and the fallopian tubes and the uterus. So laparoscopy can be used for lysis of adhesion due to endometriosis or due to infection like BID or due to previous surgery, or fulguration of endometriotic implants, or excision of endometrioma or chocolate cyst, or treatment of ectopic pregnancy. And in this case, this left tubal ectopic pregnancy can be managed by left salpingectomy through laparoscopy, or we can remove a cyst from the ovary, ovarian cystectomy or oophorectomy. We can do untwist for adnexal torsion, or we can do salpingo-oophorectomy if there is adnexal torsion with gangrenous tissue. Also, in uterine myoma, specifically the subserous myoma or pedunculated subserous myoma, can be excised through laparoscopy. We can do hysterectomy through laparoscopy, and this hysterectomy may be total laparoscopic hysterectomy or laparoscopic assisted vaginal hysterectomy. We can do other oncologic procedures like staging for malignancy, as ovarian malignancy, or second lock procedures, or we can do laparoscopic assisted radical vaginal hysterectomy. What is the preparation of the patient? We should speak with the patient, take a complete history taking, and do physical examination, and put a plan for surgery, and optimize the medical status of the patient, and educate her about what to expect from the procedure and during the recovery period. We should take informed consent, and we should give the patient idea about the therapeutic benefits and the potential risks. What about intestinal preparation? For a long time, all gynecologists use intestinal preparation before laparoscopy, but it is proved nowadays that now it is not effective. So there is no evidence that intestinal preparation is effective up till now, as is recent guidelines. However, still some gynecologists use intestinal preparation in order to have a better viewing during the surgery and preventing injury, because when the colon is not distended, help the gynecologist to see better and may prevent injuries. So you can do just simple sinus emptying. What about the patient positioning? We need the low lysotomy position, as in this picture, with angle here between the abdomen and the thigh 145 degree. Okay. Also, the table should allow Trendelenburg position with 30 degree, as in this. Usually we shift to Trendelenburg after insertion of varus needle and the first trocar of the laparoscope. Then, for secondary trocar is done while the patient in Trendelenburg position. But the varus needle and the first trocar for laparoscope is done while the patient in low lysotomy position. The idea of this position is to shift the intestine away from the pelvis, so better view for the pelvis is gained. The legs should be supported in stirrups, as here, and the curve to the knee, not to be injured also, because perineal nerve may be injured. Also avoid injury of the sciatic nerve, and keep the knee in a slight flexion to minimize stretching of the sciatic nerve and to provide increased stability in the Trendelenburg position. The buttocks, as you see, should be a little bit beyond the edge of the table to facilitate manipulation. If you insert speculum and the uterine manipulator, so the buttocks should be exceed the edge of the table little bit. Okay, as I mentioned before, this angle between the The abdomen and the size should be 145. Is ideal because it provides the surgeon adequate space for instrumentation. What about the equipment? Standard laparoscopy, telescope and its inputs to camera and the light source, optical axis can be set in different angles. As you see, this is a telescope, this is different angles. This is the video camera, light source, and the monitor, okay? The viewing system includes video equipment, should include 3-chip camera, processor, xenon light source with fiber optic cable, high resolution monitor and video recorder. The operating room allow the operating table allow third-degree flexion, as I mentioned before. This is ideal for the visualization of the deep pelvis. Don't forget the shoulder braces placed at the acromioclavicular joints and the arm placed at the patient's side, as you see here in the picture, will minimize nerve injury. Take care about the arms of the hand while you are doing laparoscopy so not to injure the hand or cause nerve injury. What about insufflator? Insufflator, for most procedures, the pneumoperitoneum may be maintained with an insufflator that flows at a rate of 2 to 7 liters per minute. High flow insufflator achieve up to 30 liters per minute are available and will maintain the pneumoperitoneum during the procedure. That allows escape of large amount of CO2 such as during tissue morcellation. So if you are doing an operative procedure with escape of CO2, so you need a larger amount of flow, okay? The idea from insufflation is to give a space inside the abdomen for better visualization and the manipulation of the organs. Carbon dioxide warmer is like this one. There is evidence that warmed CO2 is less irritating to the peritoneal surface and therefore may cause less adhesion formation. So warming CO2 is better to decrease post-operative adhesion. What about uterine manipulator? As you see in the picture, the simplest one simulating the valcellum, the single tooth valcellum in one side and uterine sound in the other side, inserted inside the uterine cavity, and this tooth fix the cervix, the lap of the cervix. Another one here associated with the head of the olive cannula for insertion with a catheter for injection of methylene blue during operation for tubal patency. Another uterine manipulator here, one with balloon fixed to fix the manipulator inside the uterine cavity. When inflated inside will fix the manipulator. Another manipulator here. So the idea from manipulator is to move the uterus in AVF or RVF or to one side, help you, the assistant will move the uterus to one side or AVF or RVF uterus, help you while you are doing the operation, especially the surgical one. What about the power instruments? We have the monopolar electrocautery, was the first methodology used for laparoscopic coagulation, then developed the bipolar electrosurgery, which is more safe than monopolar, give greater margin of safety because damage is limited by thermal spread rather than by electrical current. However, cutting ability is reduced, while the cutting ability of monopolar is much better. As you see in this picture, this is the bipolar. The laser offer a precise, rapid, and accurate method of thermally destroying the tissue although hemostatic effects are less and the cost is more. What about harmonic scalpel? Use ultrasound waves to produce cutting and coagulation. Scissors, hook, and the pole accessories are available, like laser. Decrease the hemostasis, and the increased cost must be considered with using harmonic scalpel also. This picture shows you the laparoscopic cutting devices. The first one is the bipolar electrosurgical spatula. The second one, harmonic scalpel. The third one is laparoscopic scissor. And this is the first picture, the bipolar spatula. The second one, harmonic scalpel. And the third one, laparoscopic scissor. Sorry. What about insufflator? Finish this, sorry. And we'll finish this also. Laparoscopic instruments for grasping and manipulating, as you see in this picture. The first one here is a 5 millimeter diameter grasper. This is called Maryland. As you see in the picture here, this is Maryland. And the second and the third one can be fixed in the same handle, rather graspers. Also 5 millimeter. The later one here is the claw grasper, used for holding a very big tissue. When we extract a big tissue from the abdomen, we hold it by the claw. It is 10 millimeter diameter. The next one, F and the E, is probe. Manipulating probes, 5 and the 2 millimeter. 5 and the 2 millimeter manipulating probes. The last one is grasping forceps, 2 millimeter in diameter. So, how to do intra-abdominal access? First, insufflation of CO2 through varus needle is the most common method of entry, although some would argue the open technique. So I have a closed technique using varus needle to insufflate the abdomen with CO2, or an open technique of Hasson, as I will mention later on. Okay? Varus needle is the commonest to be used by many gynecologists all over the world. This is how it looks, the varus needle. Okay? Notice this spring. This is the sharp edge, and this is a blunt one, and the opening is here, which passes CO2 inside the abdomen. The idea is when you do insertion of the varus, this is done like that with a spring to prevent trauma. Then the sharp end will cut through the layers of the abdomen until reaching the peritoneum. Then the round end or blunt end will project again, so preventing the injury of the viscera. This is the idea from varus needle with a spring. We do vertical incision at the base of the umbilicus and insert the varus needle as in this picture. Like that, we hold it between the palm and the forefinger on the shaft of the varus needle. Of course, you should test the needle before you insert it. The spring is working good. It is clear, so I can pass fluid inside the varus needle to test its patency before I insert it. Everything is fine. Then I do incision at the base of the umbilicus, then insert the varus needle in a right angle in obese patient and in 45-degree angle towards the pelvis in case of some people to avoid injury of great vessel. This is how to hold the birth needle, and this is how to insert it through the umbilicus. This is a vertical, 90 degree. Okay, the anterior abdominal wall inferior to the umbilicus is grasped with non-dominant hand, and the umbilicus is moved in caudate direction toward the feet, further displacing it below the bifurcation of aorta. This is my aim. Alternatively, the incision may be elevated by grasping the edges of the umbilical incision with two Alice clamps and lifting, as you will see here. This is, you can elevate the abdomen or move the abdomen, the umbilicus toward the caudate towards the feet, like that. So, to avoid the major vessels below the umbilicus, okay? How to be sure that the varus needle is inside the abdomen is very important. First, you will hear a double click sound while penetrating. The first one with the sheath, the second one with the peritoneum. Then, if you add saline fluid in a syringe and connect it to varus needle and aspirate to be sure there is no blood coming or bowel content, so you didn't injure a major vessel or bowel. If only pupils are visible, then you can inject the saline, which will pass through the peritoneal cavity easily. Okay, this is one test to detect that if you are inside the peritoneal cavity or not. Another test is to add 1 drop of saline to the varus needle at the top of the varus needle opening. If there is negative pressure, will enter inside the abdomen because the intra-abdomen is negative. So the drop will descend immediately. Also, if you connect the varus needle with insufflator machine and the pressure is negative or below 8 millimercury, this indicating that you are inside the peritoneal cavity. And this is nowadays in new guidelines, this is the most important sign that confirm you are intraperitoneal. Also, you can do percussion as here, and the first site to be resonant due to abdominal insufflation with CO2 is the infrahepatic area. Okay, this is another test to detect that the insufflation is good and you did it intraperitoneal. Okay, but the new guidelines confirm only the connection with the insufflator and the pressure is negative or below 8 or 10 millimercury. The insufflation tubing with CO2 is attached and the initial intra-abdominal pressure is observed. The pressure greater than 10 millimercury means that you are not intraperitoneal. You may be subcutaneous. So you should remove the needle immediately and stop flow. Okay? Because you may cause emphysema. Then try another replacement of the needle. Once intraperitoneal placement is confirmed, CO2 pneumoperitoneum is obtained, insufflation up to an intra-abdominal pressure 20 to 25 millimeters. Why we put this high pressure? First, to facilitate the insertion of the trocars, because it makes a distance between the anterior abdominal wall and great vessels and pelvic and abdominal organs. Okay, look to this picture, please. This is the trocars used. We have disposable one and we have reusable one. All of these are disposable one. The first one is 12 millimeter in diameter. The second one is 12 millimeter in diameter also, but has a deployable blade that used to cut through the abdominal wall. The next one here is 5 millimeter diameter and has a blunt conical device. The next one here, 5 millimeter in diameter also, but has a sharp conical axis. The last one is the smallest one, 2.7 millimeter in diameter. The trocar for this system is long insufflation needle with spring deployable obturator. Another trocars which is reusable from top to bottom, sharp conical device, the first one. This is a pyramidal tip design, pyramidal tip, as you see, it looks like pyramid. The third and the fourth is called endo-tip device, and this device can be positioned in the abdominal wall by simply twisting or screwing it in without the requirement of trocar. So I'm not using for this one what's called endo-tip. I'm not using trocar. I'm just twisting or screwing to introduce it inside the abdominal cavity. Okay, the end of the sharp trocar is held in the palm of the dominant hand, as you see in the picture, with the forefinger extending along the shaft and close to the sharp edge or sharp tip. The tap is inserted through the umbilical incision until fascia at the base of the umbilicus is filled. Insertion is carried through near 90-degree angle until the tap is filled to pass through the peritoneum. The trocar is then directed toward the pelvis to minimize risk of vascular or bowel injury. After placement of the primary trocar, the intra-abdominal placement is confirmed visually and the intra-abdominal pressure is reduced to 12 to 15. So you remember when I said I raise the pressure first to 20 to 25 to facilitate the insertion of the trocar? After I insert the trocar, I am now inside the abdomen. I regain the pressure to be between 12 to 15 millimercury. Open laparoscopy involve, we said before, we have a closed, what I mentioned before, and another way is called the open laparoscopy, like that of Hassoun procedure. Open laparoscopy, as in this picture, as in Hassoun procedure, inciting the anterior rectus fascia and bluntly enter the peritoneal cavity with Kelly clamp, blunt tipped trocar with a sleeve, then placed into the peritoneal cavity, as this is a clamp opening the peritoneum. Then I insert the trocar through the opening. For Hassoun technique, suture used on the fascia hold the sleeve in place and anchor the sleeve to help maintain new peritoneum. So I will fix this trocar with a suture, as you see here, the down picture here. This method avoids the risk of retroperitoneal vessel injury and may decrease the risk of bowel injury. Viewing the peritoneal cavity, the omentum, bowel, and the bifurcation of pelvic vessels should be evaluated to avoid injuries caused during the introduction of varus needle or trocar. As you see here, here is the injury of the bowel because it is maybe attached to the anterior abdominal wall or close to it, or attached by adhesions, or you may injure the vessel, one of the major vessels of the pelvis or abdomen. Okay, let us go to placement of secondary trocar. So first trocar, you inserted it to enter with the telescope inside. So the laparoscope inside, so I can see the abdomen, the pelvis. I checked for any problem happened during insertion, any injury to the vessel or organs. Then I'm going to the next step to insert a second trocar for an instrument. So after identifying the epigastric vessel by trans-elimination and intraperitoneal observation, 1 up to 3 secondary trocars are placed depending on the procedure and the number of trocars required for the operation. Sometimes quite sufficient for another secondary trocar for an instrument is quite enough. Other operation needs 2 secondary trocar. Another operation needs 3, and so on. The trocar are placed either in the midline, 4 centimeters above the symphysis pubis here, or laterally 8 centimeters from the midline and the 8 centimeters above the pubic symphysis. Why? To avoid the injury of inferior epigastric vessels. Transillumination of the abdominal wall from within permits the identification of superficial inferior epigastric vessels in most thin women. The deep inferior epigastric vessel cannot be identified by the mechanism because of their location deep to the rectus sheath. The device should be placed 4 centimeters lateral to the medial umbilical ligament or lateral to the lateral margin of rectus abdominis muscle to be safe. At the pubic crest, you should know this information. The deep inferior epigastric vessels may be seen during laparoscopy at this area between the medially located umbilical ligament and the laterally positioned exit point of the round ligament. If the insertion is placed too far laterally, you may injure the deep circumflex epigastric vessel. If you put it laterally, extreme laterally, you may injure the deep circumflex epigastric vessel, so you should take care about this. The site of introduction of other trocars should be verified by finger palpation and the trans-elimination of abdominal wall to avoid injury of epigastric vessels. Identify if there is any bleeding and you should manage immediately. Like this one, there is injury of epigastric vessels here. You can insert Foley's caster to do compression like that, and so on. Sometimes you are in need for suturing, and so on. Insertion of the trocar and the removal of the sleeves are performed under direct laparoscopic visualization while observing for signs of hemorrhage. If the trocar is larger than 8 mm, the fascia is closed with suture after removal of the sleeve to reduce risk of hernia. How to reduce post-operative pain and adhesions? By using ringer lactate to wash peritoneal cavity after you finish laparoscopy and leave behind you 500 ml of ringer lactate to reduce the incidence of post-operative adhesion and the pain. After the procedure, CO2 gas must be evacuated completely to reduce post-operative pain. If retained, it will cause abdominal pain and shoulder pain because it is radiating through irritation of the diaphragm. Many patients after laparoscopy complain of shoulder pain. Try to evacuate all CO2 gas as much as you can, especially the gas collected under the diaphragm. What about fluid management? The irrigation, wash of the peritoneal cavity. Fluid may be disseminated into the peritoneal cavity through wide caliber cystoscopy tubing, as in this picture, using gravity pressure and an infusion cuff or a high pressure mechanical pump. Which is available for you, use it. The pump delivers fluid faster than the other technique, and the highly pressurized stream of fluid may facilitate blunt dissection. So you can use the irrigation also as a blunt dissection. The type of cannula used for suction irrigation depends on irrigation fluid used and the fluid being removed. For ruptured ectopic, for example, there is bleeding, the amount of blood is maybe excess. I need for that a large diameter cannula, like 10 millimeter diameter cannula. You should know that the cannula with narrow tips are more effective in generating the high pressure needed for hydrodissection. So each one has its advantage, the narrow and wide one. Large volume of fluid are required. Isotonic fluid should be used to avoid fluid overload and electrolyte imbalance. If electrosurgery is to be performed, some volumes of non-electrolyte containing suction solution, such as glycine or sorbitol, can be used for hemostasis and irrigation, and you can use heparin, 1000 to 5000 units per liter, can be added to the irrigating solution to prevent blood clotting and facilitate fluid removal. What about tissue extraction? You have a solid tissue or tubal mass of ectopic or whatever, or ovarian mass or ovarian cyst, and you want to remove it. After excising tissue, it is usually necessary to remove it from the peritoneal cavity, as in this picture. Small samples can be pulled through appropriate sized cannula with grasping forceps. However, the large one may not fit. If the specimen is cystic, it may be drained by needle or incised, so it will shrink so you can take it out easily. To the size suitable for removal through cannula or one of the small laparoscopic incisions. If there is concern of malignancy, an alternative to place the specimen in an endoscopic retrieval bag, as this one. So I am afraid from spillage of the malignancy, so I put it inside this bag, which is well closed. More solid tissue may be morcellated with scissor or ultrasonic equipment, electrosurgery, or electromechanical morcellators. As in this picture, this is a morcellator. They cut the solid mass so I can remove it easily. More solid tissue may be morcellated with scissor also, as I mentioned before, and the morcellator. If monopolar radiofrequency instruments are used, electrosurgical morcellation, the specimen must remain attached to the patient to preserve the integrity of electrical circuit. Be careful about this point. If you are, sometimes you don't have morcellator and you want to cut the mass with monopolar radiofrequency, okay? This mass should be in contact with the patient abdomen. Why? Because to preserve the integrity of electrical circuit. Alternatively, you may use bipolar needles are available, don't require dispersive electrode. So bipolar is more safe, of course. Larger specimen may be removed by inserting larger cannula through the incision, through an incision in the cul-de-sac, what's called posterior caldotomy, okay, or by extending one of the laparoscopy incision like that at the umbilicus. You may widen the incision at the umbilicus for 3 centimeters and remove it, and it will be cosmetic. When the umbilical location is selected, removal of the tissue can be directed from an endoscope positioned in one of ancillary ports. So I need to see the view inside the abdomen. So I put another telescope in one of the 5 millimeter port of secondary trocar, secondary sheath. The ancillary one, I put the telescope, the small one, 5 millimeter, and I put the grasper, the claw, which will pick up the mass through the abdomen, through the trocar of the umbilicus, which used before for telescope. Okay, You understand this? So I'll change the position of telescope. What about the incision? Should be managed? Yes, of course. If the incision is 10 millimeter, you should repair the fascia to prevent occurrence of hernia. Then you repair the skin. If it is 5 millimeter or less, you are not in need to repair the fascia, just repair of skin and subcutaneous if there is any spurter or bleeder. Small caliber laparoscope passed through one of the narrow cannula can be used to direct the facial closure using curved needle, so not to injury any loop of intestine. What is the procedure for large vessel occlusion? Maybe traditional suturing with intracorporeal or extracorporeal, no tying. Okay, and it was used for a long time ago, but it is difficult and needs skilled personnel, and it takes time. The first technique developed to assist occluding large vessel with pre-tied suture loop is called the endo loop. It was simple, quick types of loop, but the disadvantage can loosen in the immediate post-operative period, so it is not successful so much because it can loosen post-operative. Linear stapling devices has been used for occluding vessels during hysterectomy and the adnexal removal. Bipolar electrocautery, one of the best really and least expensive approach for occluding large vessels. What about laparoscope with an integrated straight channel? This is laparoscope containing two channels, one for the lens and the imaging, and another one for insertion of instrument. So you can use it as a diagnostic at the viewing of the abdomen, and the same moment I can insert an instrument. Also, I can use laser through it. Okay? But still, the standard viewing only laparoscope permit better visualization at a given diameter. So, the view with this one laparoscope with integrated straight channel, which has another channel for an instrument, is a relatively larger in caliber than a standard laparoscope, and they may have smaller fields of view, and they may present increased risk associated with the use of monopolar electrosurgical instrument. What is the advantage of laparoscopy? Of course, it's a minimally invasive procedure with less hemorrhage, smaller incision, more cosmetic, reduced pain, and shorten recovery time, as well as resulting in less operative scarring, hospital discharge yearly than any laparotomy, and less pain, so less pain medication also needed, reduced risk of acquiring infection. All these are advantages. So what is the complication? Trauma, especially during entry of the first needle and first trocar. The injury may be major, affecting the viscera, intestine, bladder, and so on, or maybe injury of the ureter or major vessels, or the trauma may be minor. Overall, the incidence of entry injury range between 0.3 to up to 1%. There may be thermal injury with use of electrosurgical procedure, maybe hernia formation if you use trocar 10 millimeter or more, infections, hemorrhage, problem associated with anesthesia, there may be hypotension, there may be cardiac arrhythmia, there may be peripheral nerve injury related to positioning of the patient. So I said at the start, you should take care about position of the patient. There may be carbon dioxide embolism. Also, extraperitoneal insufflation may cause subcutaneous emphysema, mesenteric or mental emphysema, and mediastinal and neck emphysema, which is very dangerous. In mild cases of emphysema, you do nothing, you continue the operation, but you be sure that the needle inside the varus needle and the trocar inside the peritoneal cavity, so all CO2 is inside the peritoneal cavity, and there are no leakage anymore. But in severe cases that reach the face, as in this picture, and the neck, may cause mediastinal emphysema with pneumothorax, hypercarbia, and even cardiovascular collapse. As in this picture, the pneumothorax. This is dangerous, really, and you should stop the procedure immediately and follow up with the patient for evidence of pneumothorax and do X-ray chest. If proved pneumothorax, you should insert chest tube in the second intercostal space, 14 to 16 gauge. Let us go to the last item in our lecture, which is the Canadian Society of Obstetrician and the Gynecologist guideline and recommendation. First, about the entry, they put this recommendation for the entry, really. Laparoscopic entry using varus needle, pneumoperitoneum trocar technique is practiced by the majority of gynecologists worldwide. During closed entry, caudal umbilical displacement below the sacrum and the great vessel facilitate intraperitoneal placement of varus needle and maximize the success entry and avoid injury. The varus needle can be inserted intraperitoneally at umbilical or left upper quadrant side. Left upper quadrant placement is associated with fewer attempts and fewer conversion to alternative sites. Initial varus intraperitoneal pressure of less than 10 mmHg is the most reliable indicator of correct vessel varus needle placement. Shielded trocar don't result in fewer visceral or vascular injury during laparoscopic access. The plumb tip of radially expanding trocar may provide protection from injuries, but the force required for entry is significantly greater than for disposable trocars. Single-use push-through optical trocars are not superior to blind methods of inserting trocar and don't avoid visceral or vascular injury. Reusable visual entry cannula have no sharp or pointed trocar, minimize port wound size, and reduce insertional force. As a consequence, they may be safer than trocars. Direct trocar insertion is associated with fewer insufflation complication and failed entries. However, there is insufficient evidence to conclude that the direct insertion is associated with fewer major complications. Open entry is neither superior nor inferior to the other entry, to the closed entry, I mean. Open entry has a lower incidence of vascular injury, but potentially higher incidence of bowel injury. Is laparoscopy can be performed in pregnancy? Yes, can be performed in pregnancy. What about recommendations of the Canadian Society Guidelines 2020? Alternative insertion sites for the varus needle, example, left upper quadrant, what's called Palmer's point, transvaginal or transuterine should be considered when an umbilical entry is considered complicated based on patient history and the characteristic like periumbilical adhesions, history of presence of umbilical hernia, low or high body mass index. 2. After 3 failed attempts at umbilical varus needle insertion, it should go to the alternative site of insertion. Elevation of the abdominal wall during insertion of varus needle or primary trocar is not routinely recommended because it doesn't avoid visceral or vessel injury. Because the position of the umbilicus in relation to the aortic bifurcation varies according to the patient body mass index, The angle of insertion of the varus needle at the umbilicus should be adjusted accordingly from 45 degree in women of normal body mass to 90 degree in women with obesity. Previously recommended varus needle safety checks or tests such as saline drop test and aspiration for fluid have not been found to confirm position, and therefore they are no longer recommended as a best practice. Wiggling the varus needle from side to side should be avoided. Why? Because increasing the risk of complications. It is appropriate to leave the source of gas attached to the varus needle so that the surgeon can use the pressure gauge to measure the intraperitoneal pressure. If it is less than 10 millimercury as the most reliable indicator of correct placement of the varus needle. The volume of CO2 insufflated with varus needle before trocar insertion should depend on intra-abdominal pressure. Adequate pneumoperitoneum insufflation should be determined by a pressure of 20 to 30 millimercury rather than by CO2 volume. Of course, I'm not depending on the volume, I'm depending on the pressure. During entry using varus needle insufflation, intraperitoneal pressure may be increased immediately before insertion of the trocars. Transiently, high intraperitoneal pressure doesn't adversely affect cardiopulmonary function in a healthy patient because it's just temporary. The threaded, reusable visual cannula may be considered a safer instrument for peritoneal entry than conventional trocar, as this one in the picture. Direct trocar insertion may be used in accordance with the surgeon training, experience, and the preference. The open method, what's called Hassoun entry method, may be used in accordance with the surgeon training, experience, and the preference, because there is no clear consensus on the optimal method of peritoneal entry. Surgeon should use the technique with which they are most comfortable and experienced. So, as a gynecologist, do what you do it perfect. Is it closed or open one, but do it perfectly. In women requiring intra-abdominal surgery in pregnancy, varus needle insufflation at the umbilical site can be employed until 14 weeks gestation. And the open entry or left upper quadrant insufflation are preferably after 14 weeks. So, below 14 weeks, I can insert through the umbilicus. After 14 weeks, I may use left upper quadrant or I may use open method of Hassoun. After 24 weeks gestation, I should use open method of Hassoun. Thank you. I'm Dr. Alam Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura